Hi, everyone. In today's podcast, we're going to talk about our newest evidence-based birth signature article, The Evidence on Fetal Monitoring. Hi, everyone. I'm so excited to welcome you back to another episode of the Evidence-Based Birth Podcast. We're taking a little break in our pain management series to turn to an important article that was just published at Evidence-Based Birth, and that is the evidence on fetal monitoring. Fetal monitoring was one of the first topics that I looked at the research for when I started Evidence-Based Birth in 2012. I wrote an informal blog article about the evidence on fetal monitoring. And this year, with the help of my research assistant, Anna Bertoni, we took that article, updated it, and put it through the signature article process to turn it into a peer-reviewed article that's available on the Evidence-Based Birth website at ebbirth.com/fetal monitoring. Today, I want to give you an overview of this article, and I also want to talk about the challenge that we're doing. So for the next 30 days, we are doing a free challenge that you can participate in. We have a free private Facebook group that challenge participants can join. And you also get access to the full-length printer-friendly PDF of the signature article on fetal monitoring. Basically, what we're asking everybody to do is to share the evidence, to share this printer-friendly PDF with someone that they know. And we're trying to spread the word about evidence-based fetal monitoring. We did a similar challenge about a year ago with the eating and drinking article, and it had a huge impact. At least in my opinion, even in my hometown, one nurse shared with me that after he read the article, a local obstetrician told her that he'd changed his mind about the evidence on eating and drinking as a result of reading that article. So to get started, either just check your email if you're already a subscriber to the Evidence-Based Birth newsletter, and you will see a link to join the free Facebook group and instructions on how to get the PDFs. If you're not already on our email list, just go to ebbirth.com/fetal monitoring and click on the blue button at the top of the article to get the downloads and to start your journey in this 30-day challenge. So now let's get started. What did we find in this article? In the beginning of the article, we start off by defining the different types of fetal monitoring. And for the purposes of this article, when I say fetal monitoring, I'm talking about fetal monitoring during labor, not fetal monitoring tests that might be done at the end of pregnancy. Electronic fetal monitoring is also called EFM, and sometimes it's called cardiotachography or CTG. This is when the baby's heart rate is monitored with an ultrasound machine while the mother's contractions are monitored with a pressure sensor. Both of these sensors are linked to some kind of recording machine, which shows a printout or a computer screen of the baby's heart rate and the mother's contractions shown together, and this is called EFM tracings. According to the Listening to Mothers 3 National Survey, which was published by de Klerk et al. In 2014, EFM, or electronic fetal monitoring, was used by about 89% of mothers who gave birth in U.S. hospitals in 2011 and 2012. Many hospitals use continuous electronic fetal monitoring during labor. Continuous means that you're hooked up to the monitor continuously and that caregivers are continuously assessing the EFM tracings. Intermittent is a word that means using something at regular time intervals and not using it continuously. In the Listening to Mothers survey, most mothers described using electronic fetal monitoring either continuously, 60%, or for most of the time during labor, 20%. For about 23% of mothers, EFM was used intermittently during labor or for a short time after hospital admission as a baseline measure. Intermittent electronic fetal monitoring is fairly common, but it hardly has any research evidence backing its use, and we'll talk more about that in a little bit. Another type of fetal monitoring is something called hands-on listening. This is usually referred to as intermittent auscultation, which literally means listening at regular time intervals. But my research assistant and I decided that perhaps that name is holding back this practice. So we decided to give it an easier to understand name for parents, and that is hands-on listening. With hands-on listening, the caregiver listens to the fetal heart rate for short periods of time at regular intervals. While listening, the care provider also feels the mother's contractions by placing a hand on the mother's abdomen and then documenting the frequency, duration, and intensity of the contractions, as well as what is going on with the fetal heart rate. Hands-on listening by itself is only used with about 11% of mothers giving birth in U.S. hospitals, and it's the main method of checking fetal well-being at planned home births and freestanding birth centers. Hands-on listening is a hands-on practice. You literally have to put your hands on the person and listen to their baby's heart rate for at least 1 minute, and then you need to do that at least every hour during early labor, every 15 to 30 minutes during the active phase of the first stage of labor, and at least every 5 to 15 minutes during the pushing phase of the second stage of labor. There are different devices that you can use for hands-on listening. The most popular option in the United States is probably the handheld fetal Doppler ultrasound device. This is a small handheld device that detects the fetal heartbeat and converts it to sound, which you then hear out loud. There are several other stethoscope options for listening to the fetal heartbeat and using hands-on listening, and we describe those in the article. Now, using the electronic fetal heart rate monitoring machine continuously became a thing in the 1970s. This practice was introduced with a strong marketing push from the monitoring industry without evidence from clinical trials. They marketed this machine as a scientific breakthrough that could predict fetal distress and bring an end to cerebral palsy. It was embraced by most hospitals, obstetricians, and many nurses. Today, the use of continuous EFM machines is widespread across the United States, and it's even starting to spread in developing countries. However, we still lack evidence of benefits. Electronic fetal monitoring was used among 45% of laboring women in 1980, and then that number went to 62% in 1988, 74% in 1992, and 85% in 2002. Today, as I mentioned earlier, the rate of EFM during labor is around 90%. During the same time frame between 1970 and 2016, the cesarean rate in the U.S. increased from 5% to 32%, and quote, non-reassuring fetal heart tones, end quote, is now the second most common reason for having a first-time cesarean in the United States. So what's the evidence on this practice, on continuous electronic fetal monitoring, and what's the evidence on the alternative of hands-on listening? So in 2017, Cochrane researchers led by Alfie Revick et al. Combined the results of 12 randomized controlled trials that had more than 37,000 participants. Most of these studies were of poor quality and took place in the 1970s and 1980s. It's important to note that both technology and clinical practice have changed over the years, and we don't know what results researchers would find if they redid these studies today. In all of these randomized trials, people were randomly assigned, like flipping a coin, to receive either continuous EFM or hands-on listening during labor. The researchers found no differences for babies between the continuous electronic fetal monitoring group and the hands-on listening group in APGAR scores, cord blood gases, rates of low oxygen brain damage, admission to the neonatal intensive care unit, or stillbirth or newborn death. They also found no difference between groups in the percentage of people who used medication for pain relief during labor. The overall findings were consistent for people with low risk and high risk pregnancies. So people with high risk pregnancies were included in this analysis. When the researchers removed the worst quality trials from the analysis, it did not change the overall findings. Now, where they did find differences were with newborn seizure rates, cesarean rates, and forceps and vacuum delivery rates. There was a lower risk of newborn seizures in the continuous electronic fetal monitoring group. However, overall, seizure events were rare. The risk of a newborn seizure was 0.15% for people with continuous EFM versus 0.3% for people who had hands-on listening during labor. The Cochrane researchers say that there have not been any long-term follow-up studies looking at the harms of newborn seizures, so we don't know how important preventing a seizure is to the long-term health of a child. Another finding was that people in the continuous electronic fetal monitoring group were much more likely to have a cesarean and more likely to experience the use of vacuum or forceps when compared to people in the hands-on listening group. The overall cesarean rate, or the total cesarean rate, varied widely between the different studies. One study had an overall cesarean rate of about 2%, which is unheard of today, and another study had a cesarean rate of 35%. However, most of the data on cesarean rates in the Cochrane review came from the study with that overall low cesarean rate of 2.3%. In the meta-analysis, the study done by the Cochrane researchers, the overall risk of cesarean was 3.6% for people who received hands-on listening and 5.9% for those receiving continuous electronic fetal monitoring. Of course, these kinds of really low cesarean rates are pretty much unheard of in hospitals in the United States. The Cochrane researchers estimated that if the cesarean rate were increased to a more modern rate of about 24% among people receiving continuous electronic fetal monitoring, then the cesarean rate would be 15% among those receiving hands-on listening. This means that there would be one additional cesarean for every 11 women monitored by continuous EFM. In addition, they state that as many as 667 women would have to be continuously monitored with the EFM machine in order to prevent one newborn seizure event. This calculates to an estimated 61 unnecessary cesareans from continuous EFM in order to prevent one newborn seizure event. As you can see, they're focusing their debate on preventing cesareans versus preventing newborn seizures, and not everyone agrees on which is more important to prevent. Now, it's likely that the effect of continuous EFM on the cesarean rate may be even greater in real-world hospital settings today. In an earlier version of the Cochrane review that they published in 2006, the researchers grouped studies with a lower cesarean rate and those with a higher cesarean rate and did separate analyses. And they found that if your hospital has a higher cesarean rate, continuous EFM leads to an even higher risk of needing a cesarean. Importantly, the Cochrane researchers did not find any difference in the rate of cerebral palsy between the continuous EFM group and the group who received hands-on listening. This is consistent with many other researchers who have found that continuous electronic fetal monitoring is a very poor test for detecting potential cerebral palsy. The rates of getting a false positive for predicting cerebral palsy are as high as 99.8%. To put it another way, most positive test results for cerebral palsy during labor will be wrong. That false positive rate is so high that for every 1,000 babies with an abnormal fetal heart rate pattern that indicates cerebral palsy might be at risk of happening, only 1 or 2 out of those 1,000 will go on to develop cerebral palsy. And in fact, the rate of cerebral palsy has stayed the same over time, despite the widespread adoption of using EFM during labor. The rate remains about 1 out of 500 children, and that rate remained steady since 1985. There was a review published in 2013 by Ellenberg and Nelson that looked at 23 studies to determine how often a lack of oxygen to the baby during birth is linked with cerebral palsy. And they found that the majority of cerebral palsy cases were actually due to prenatal factors before labor begins, and thus those majority of cases cannot be prevented by electronic fetal monitoring. Now, as I already said, the meta-analysis of randomized trials shows that continuous EFM does not have an effect on stillbirth or newborn death. However, the problem with randomized trials is that a rare outcome like stillbirth or newborn death, because it's so rare, you need a very large sample size to tell a difference between groups. The Cochrane reviewers, Alfie Revick et al., estimated that more than 50,000 women would have to be randomly assigned to continuous EFM or hands-on listening in order to detect a difference in one death out of 1,000 births. Since that Cochrane review only included around 37,000 participants, there is a chance that continuous EFM has an effect on stillbirth that could not be detected in this review. Now, rates of stillbirth during labor were already falling when continuous electronic fetal monitoring was introduced in the 1970s, which makes it difficult to interpret the evidence from before and after studies. In the year 2000, a research team led by someone named Hornbuckle looked at 13 observational studies to see what the stillbirth rate was in hospitals before and after they introduced continuous EFM. 12 of the 13 observational studies did show a decrease in stillbirths during labor. In addition, there were 9 observational studies that compared labors monitored with continuous EFM with those monitored versus hands-on listening. So this was not randomized, but it also wasn't a before and after. They simply took those different types of people who received the different monitoring and compared them. 9 out of 9 studies did find that continuous EFM showed lower rates of stillbirth during labor. On average, the stillbirth rate in the continuous electronic fetal monitoring group of women who were low risk was lowered by about 0.5 stillbirths per 1,000 births. Now, studies of this observational type do provide lower quality evidence in randomized trials. There could be something that we call publication bias, where researchers are more likely to publish studies which show falling death rates with continuous electronic fetal monitoring. On the other hand, there could be a true relationship between continuous EFM and lower stillbirth rates. However, if continuous EFM leads to a decrease in stillbirths during labor, this does not necessarily mean that continuous EFM should be used all the time for everyone. Any decrease in the risk of stillbirth would be very small, especially among low-risk women. So using the observational data, they estimated that it was a decrease of 0.5 per 1,000 births. And in the Cochrane review, stillbirths were so rare that even in 37,000 people, they couldn't detect a difference. On the other hand, the known increase in cesarean rates with continuous EFM is very large. It's for this reason that practice guidelines around the world discourage the routine use of continuous EFM during labor. These include organizations such as the Society of Obstetrics and Gynecologists of Canada, the National Institute for Health and Care Excellence in the United Kingdom, the American College of Nurse Midwives, and the California Maternal Quality Care Collaborative in the United States. So that's the bulk of the evidence on continuous electronic fetal monitoring versus hands-on listening. In the signature article that you can access at ebbirth.com/fetal monitoring, we go on to talk about the evidence on intermittent electronic fetal monitoring, the evidence on mobile continuous electronic fetal monitors, different types of hands-on listening, such as the different types of stethoscopes compared to a handheld Doppler, the evidence on admission monitoring. And so if you want to learn about the evidence on these different types of monitoring, I'd encourage you to visit the article. If I had to summarize the pros and cons of hands-on listening, I would say that the pros include a lower rate of cesareans and vacuum and forceps delivery. Hands-on listening does support movement in upright positions during labor because it frees them up to be mobile. It can be used during water therapy in a tub or a shower. The devices for hands-on listening are relatively inexpensive, and hands-on listening leads to more continuous support and hands-on support from your providers during birth. The cons or drawbacks of hands-on listening include a higher rate of newborn seizures. The risk with hands-on listening of a newborn seizure was 0.3% in research studies from the 1970s and 80s. It may not be appropriate for people with complications who need more intensive monitoring. Hands-on listening also requires hands-on care, which is not supported in all birth settings. There's no automatic recording of the fetal heart rate tracings, which may lead to uncertainty if there's a lawsuit. And hospital staff may not be well trained in using this method. On the other hand, if we summarize the pros and cons of continuous electronic fetal monitoring, the pros include a lower rate of newborn seizures at 0.15%. There are some monitors that are wireless and water resistant, although they are not frequently used. And care providers can use the recording in the event of a lawsuit, although we talk in the article about how often the fetal heart rate tracings are used against the hospital in lawsuits as well. The main drawbacks of electronic fetal monitoring are the higher rate of cesareans, forceps, and vacuum. Most monitors require you to be restricted to bed. The monitor may be uncomfortable and distracting to both the family and the person who's giving birth. And patients have reported that nurses may focus more on the monitor and pay less attention to the patient because coordinating and taking care of the machine and monitoring the readings of the fetal heart rate tracing can take up a lot of their time. Hands-on listening is an evidence-based option, and it's probably best practice for most mothers and babies. But it's rarely used in the United States. Why is that? Well, we go into more detail about this in the article, but one of the reasons is liability. I already kind of mentioned that in the pros and cons. One of the main reasons that hospitals either state that they require electronic fetal monitoring or they try and get as many people as possible to use it is that doctors, nurses, midwives, and hospitals think that it protects them from cerebral palsy lawsuits. However, several articles published by Spector Baghdadi and Sartwell in 2017 talk about how the introduction of EFM actually increased rates of medical malpractice lawsuits. After EFM was introduced, doctors began relying on the new recordings as their defense against cerebral palsy. However, people suing them were able to use those same recordings against them in court, and trial lawyers for parents were able to win billions in lawsuits against physicians. Now, one of the main problems with EFM and lawsuits is that today, judges and juries in the United States decide on whether or not a provider committed medical malpractice based on something called the standard of care. Standard of care means how did this doctor practice compared to how other doctors in their community are currently practicing. This does not mean evidence-based practice. It just means, are you practicing like all the other doctors in your town? This puts doctors, nurses, and midwives in a bad scenario. If a baby has a bad health outcome and the hospital is unable to produce an EFM strip or reading as, quote, proof for the court, this can be seen as a failure to meet the standard of care. And if you don't have an EFM tracing or recording, it increases the chance that the hospital will lose the lawsuit or have to settle the lawsuit, which is going to be very expensive for them either way. Other barriers to evidence-based fetal monitoring include a lack of resources. Many hospitals don't own a handheld Doppler, or they only own one or two and they go missing. Time, so it actually takes time, hands-on time, to listen to the fetal heart rate and palpate the woman's contractions with your hand. Whereas with electronic fetal monitoring, often they can just watch you from the nurse's station on the computer screen. I think marketing is another reason. Electronic fetal monitoring is a big business, and there are big companies that are pushing this technology on hospitals. Another barrier to hands-on listening is training. Most nurses and doctors are probably not familiar with using a fetal stethoscope, and many have very little or no training in hands-on listening. In specialty training for nurses on electronic fetal monitoring that they take after getting out of nursing school, the bulk of the content that they learn is focused on electronic fetal monitoring with very little time reserved for hands-on listening. So those are some of the barriers and some of the reasons why the rate of hands-on listening in the United States is so low at 11%. And yet current guidelines on fetal monitoring across the world recommend hands-on listening. So we have a gap between what the evidence says should be an option for families and even what the professional guidelines say, and then what's actually happening in hospitals. And in many birth settings, low-risk people who are totally appropriate for hands-on listening are still told that electronic fetal monitoring, either continuous or intermittent, is, quote, required during labor. The reality is that there are system pressures in hospitals that limit doctors, midwives, and nurses from truly supporting birthing families. Too few nurses and increased computer duties limit a nurse's ability to perform hands-on listening. If hospitals were willing to invest in more hands-on care to support women during childbirth, we would likely see more hands-on listening. The bottom line is that hands-on listening is an evidence-based option for mothers and babies, and we need to spread the word to put pressure on the system so that it becomes a priority to change this practice. So again, I'd love to invite you to join our challenge for the next 30 days. We're going to be sharing this evidence, sharing the PDFs, sharing the link to the blog article, sharing this podcast so that people can read the evidence for themselves, think about the practices that are going on in their community, and brainstorm ways we can improve care for families. That's it for today's podcast. I also wanted to give you a heads up that we have a lot of evidence-based birth live events going on in the United States and Canada this summer. You can find a list of all these events by going to facebook.com/evidence-based birth and clicking on events. We have workshops and classes for parents and professionals going on in Pennsylvania, Michigan, Nebraska, New Jersey, San Diego, California, Richmond, Virginia, Toronto in Canada, and Tennessee. And that's just June and July. In August, we already have events scheduled for Denver, Kentucky, Tennessee, and Michigan. So I encourage you to check out our Facebook events page and see if there's an event going on near you where you can go learn directly from an evidence-based birth instructor. That's it for this podcast. Thanks for listening. Next week, we're going to return to our pain management series and talk about the evidence on hypnosis for relieving pain during labor. Thanks, everyone. Bye.